Hi everybody, welcome to Dr. Manny's YouTube Learn Shops. This is chest x-ray interpretation part 3 and we'll be looking at black or radiolucent images which are created on a chest x-ray. The objectives for this session are to review and identify common anomalies, diseases, conditions which may create a black image, a radiolucent image, an image of decreased density on a chest x-ray. Now you have to remember normal blackness. Normal blackness is radiolucency or radiolucent images or images that have got air within them in the right places. Tissues that typically have air or blackness associated with them are the trachea and the primary bronchi, the stomach with its gas bubble, typically situated under the left hemidiaphragm. Already mentioned here the trachea and the primary bronchi as seen on the x-ray, and the lungs, the right and left lung, which are typically black with vascular markings because they're full of air. Now you also have to remember there are images that are created with abnormal blackness and radiolucent images that are in the wrong place. So remember, too black, too big, wrong place. And this is related again to tissues and organs such as the trachea, the primary right and left bronchus, the lungs, the stomach, remember, has got a gas bubble under the left hemidiaphragm, not the right hemidiaphragm. So as we can see by the image that's been created on this chest x-ray film, which is dextrocardia with situs inversus, which we'll be looking at when we look at part 4 in chest x-ray interpretation, anomalous cardiac images. But as you can see, the heart's in the wrong place, the lungs are in the wrong place, right and left are transposed, right is where left should be, left is where right should be. Gas bubble is under the right hemidiaphragm, whereas it should be under the left hemidiaphragm. Okay, what is this blackness, or this radiolucency? Blackness occurs on a chest x-ray film due to decreased density air, as we've discussed previously, and it's in an intrathoracic structure. There's technical blackness, which is due to a technical issue. The radiographer, when taking the x-ray, possibly for some reason over-penetrated or used too much x-ray beam, or had the camera sighted too close to the person, which increased the intensity of the beam radiation on the x-ray film, increased exposure. Now there can be deliberate technical blackness which the radiographer may employ when taking a film to highlight possibly a foreign body or a possible pneumothorax. And this is deliberate overexposure or overpenetration. So as you can see on the film, there are 3 foreign bodies. Some of them are unintentional and 1 is intentional. The first 2 have been inhaled or swallowed, and the last one is a ring, tricuspid valve. Now, some of the more common conditions on an anterior-posterior film that can be seen is COPD, chronic obstructive pulmonary disease, sometimes referred to as COLD, chronic obstructive lung disease. And chronic obstructive disease is a common lung disease. There are two main forms of chronic obstructive pulmonary disease, which are typically chronic bronchitis and emphysema, with a variety of different variations. Signs of chronic obstructive pulmonary disease are as a result of the disease process with air trapping. So you have hyperinflated and therefore hyper radiolucent lungs, which increase the lung surface area because air can't escape very effectively. When you look at the patient physically over a period of time, they have a big barrel chest. Other signs of COPD include increased vascular markings, and the two arrows are highlighting the hilar. The hilar is the region where blood vessels enter and leave. So therefore you've got your pulmonary arteries, you've got your pulmonary veins, your pulmonary lymphatics, and nerves associated with these two areas. And the increase in vascular markings is primarily due to pulmonary hypertension, which is one of the side effects of having chronic obstructive pulmonary disease. Other signs of COPD include wide intercostal spaces. And as I indicated previously, this is because of air trapping, and if you saw the patient, the anterior posterior diameter would be equal to their lateral diameter, which means that they have a barrel chest. Because air can't escape as easily as you and I with normal lungs, normal airways. Other signs of COPD include horizontal straight ribs. Again, because over a period of time with chronic air trapping, the chest physical features change. Lungs become less elastic, less compliant. Other signs of COPD, because of air trapping again, are flat hemidiaphragms. Diaphragm is pushed down. An additional sign that is typical in COPD is a long, elongated mediastinum. The heart seems to be stretched. The aorta seems to be stretched. And this is because the heart is attached to the sternum, it's attached to the diaphragm, and as a consequence of air trapping and an increase in the chest wall size, barrel chest, the heart image is stretched. It doesn't affect the function of the heart, it just changes the image on a chest X-ray. Now, when you have severe chronic obstructive pulmonary disease, in some instances you can develop aneurysms within the lungs themselves called bullae, large emphysematous sacs, or blebs, small emphysematous sacs. But the blebs can eventually become bullae because of damage to the lung tissue. So severe signs of COPD are these aneurysms, or these big areas of dead space, and these are referred to as emphysematous bullous or air sacs that are like aneurysms in the lung. Here's an example of severe COPD, sometimes referred to as the vanishing lung syndrome, because with COPD, depending on the cause, there's progressive lung destruction, and this is when the bullous or the large aneurysm occupies more than a third of the hemithorax, which means a third of the lung tissue is actually destroyed, or more than. And how you recognize that is because you've got increased blackness on the affected side compared to the other side, there are no vascular markings. And if there are no vascular markings, this either indicates a pneumothorax or it indicates that you have a bullous or a bleb. Now let's move on to barotrauma. Baro, Latin, pressure. Trauma, you know. So barotrauma is pressure trauma. And this is tissue injury caused by pressure-related changes in the thorax's gas volume. And factors that increase the pulmonary barotrauma include rapid ascent, breathing, breath holding, breathing compressed air, which sometimes you do when you skin dive, and lung disorders such as COPD, which we've just reviewed. And as you can see by the chest x-ray, yes, the lungs are black. This is a classic COPD chest x-ray. However, the right lung is completely collapsed. There are no vascular markings there. This is a form of barotrauma called pneumothorax, which we'll be reviewing. So here's pneumothorax. Pneumo, air, thorax, chest. So this is a collapsed lung. And this occurs when air leaks into the pleural space, which is between your lung and the chest wall. And typically the pleura is occupied by a little bit of fluid called pleural fluid, typically around about 20 to 30 mils. It doesn't have air in it. And a pneumothorax, the air is in the pleura, and sometimes the air can push and make the lung collapse as a consequence. Depends on how big the pneumothorax is. So when you look at the chest x-ray in front of you, note the left side has got no vascular markings. The lung is completely collapsed. With a pneumothorax, you can get what is called the sulcus sign. And the sulcus sign is basically seen with a patient who's had an AP film taken in the supine position. And a sulcus just means a depression or a deep groove. So you can call it the sulcus deep groove sign. And it represents radiolucency or blackness of the lateral costophrenic angle extending towards the hypochondrium or the ribs. So when you look at the chest x-ray in front of you, make a comparison. Always make a comparison. Look for synchrony. Right versus left. Yes, the right lung and the left lung are marginally different, but essentially they're the same. The blackness should be the same. The whiteness should be the same. The diaphragm should be the same. The hilar should be the same. On this chest x-ray, you've got increased blackness. The lung is completely collapsed. If the pneumothorax becomes more problematic, it can become what is called a tension pneumothorax, which means it places the chest under a lot of tension. And this occurs when intrapleural air accumulates progressively in such a way to exert positive pressure on the mediastinum and the intrathoracic structures, especially the heart. And when a tension pneumothorax occurs, it's considered to be a life-threatening occurrence. You'll recognise that anyway when you see your patient in the flesh, when you do their physical assessment. And this requires both rapid recognition and prompt treatment to avoid a cardiopulmonary arrest. So if you look at the chest x-ray in front of you, look at the lungs. You would have already identified that you've got no air entry with auscultation on the right side. And as a consequence of air accumulating in the pleura, what happens is it compresses the right lung. There's nowhere for the air to escape to, so it compresses even further, pushing down the hemidiaphragm. It pushes the heart to the left side, if it's a right-sided tension pneumothorax, causing mediastinal shift, which ultimately compresses the left lung. And as a consequence of all this tension and compression and accumulation of air in the right pleura, you get tracheal deviation. So, what you would see on the chest X-ray as you see in front of you, you'll see tracheal deviation. There'll be no vascular markings on the left side because the lung is being compressed. The hemidiaphragm on the left side is also being compressed, so the liver is being pushed down. As a consequence of all this, the left lung is being compressed, the heart is being compressed, which you'll see as mediastinal shift. A life-threatening condition. Now, tension pneumothorax, as seen here on a paediatric patient, you can still see some of the lung inflated on the left side, but make the comparison. See the blackness, you've got increased blackness, left hemidiaphragm is being pushed down, you've got the left lung being compressed, you've got a degree of tracheal deviation, you've got some mediastinal shift and some compression of the the right lung. Even though hemothorax is part of the radio-opaque X-ray, I've just included here just to give you an idea. So this is a combined Pneumo-Hemothorax. And as you can see with the hemothorax, this must have been taken in the erect position or the semi-erect position as an AP film. And you can see the fluid level for the hemothorax. So if I told you here that this patient was a chest trauma with contused lung, fractured ribs, this would explain the bleeding in the chest and the accumulation of blood in the pleura. So you've got a combined pneumothorax, air, increased radiolucency or blackness on the left side, in the left upper lobe, and you've got a hemothorax, increased radioopacity, whiteness, in the left lower lobe. Another example of a pneumo-hemothorax taken in the Decubitus position. And as I said, it's a combination of two medical conditions. And just to repeat, pneumothorax occurs when air enters the pleural cavity. Hemothorax occurs when blood collects in the pleural cavity. And here you've got the person being positioned on their side, the affected side. Air gravitates up, fluid, blood gravitates down. And you can see a fluid level. And you can see the pneumothorax. Another form of barotrauma is a Pneumo-mediastinum. Pneumo air, mediastinum middle space. It's also known as mediastinal emphysema, and it's a condition in which air is present in the mediastinum. And the mediastinum, as we've indicated previously, is the space in the chest between the two lungs. This is where the heart sits, superior inferior vena cava is contained, the ascending, descending arch of the aorta, the esophagus, the trachea, the primary bronchi, a number of different glands, the mediastinum. And a pneumomediastinum can be caused by a traumatic injury, which can be associated with typically a pneumothorax in relation to other diseases such as chronic obstructive pulmonary disease. And a sign of pneumomediastinum or Pneumo-pericardium is blackness. of the diaphragm, under the heart. So there's a continuous line from the diaphragm, right hemidiaphragm, under the heart to the left hemidiaphragm. This is not normal. Normally, there's no continuous sign or the continuous diaphragm sign under the heart shadow. This is a sign that there is air in the pericardium or in the mediastinum. So as I said, Pneumo-mediastinum has got what is called the continuous diaphragm sign. And it's not seen unless there's air in the pericardium or in the mediastinum. Look under the heart shadow, see the line of blackness. This is not normal. Another example of the continuous diaphragm sign. Then you've got Pneumo-pericardium. Now the pericardium is the sac which the heart is contained in. And this is a medical condition where air enters the pericardial cavity, barotrauma, as a result of barotrauma. And this condition has been recognised in preterm neonates, in which they're associated with severe lung disease, because sometimes they require high oxygen levels, they've got low surfactant levels, they develop eventually a form of chronic lung disease as a result of bronchopulmonary dysplasia and the treatment that they have as a consequence of their prematurity. Spontaneous pneumopericardium and mediastinum is also defined as free air within the mediastinum, and it may not be associated with trauma. And this can occur when you're exercising too much. However, there has to be some sort of precondition that results in spontaneous pneumothoraces. Certain medications may initiate it. Asthma, absolutely, with high airway pressures. Vomiting can initiate a pneumopericardium. Breathing difficulties, such as during pregnancy and labour, and certain Valsalva manoeuvres where you increase intrathoracic pressure as a result of increasing intra-abdominal pressure. Now remember that the cardiac image is white because the heart is tissue. It's full of blood. It's radio-opaque. It shouldn't be black. If it's black, then you've probably got air within the pericardial sac. Here's an example of pneumopericardium. Subcutaneous emphysema is another form of barotrauma. And subcutaneous emphysema, sometimes referred to as surgical emphysema, refers to trapped air in the skin. However, if you're going to refer to it technically, unless it's been caused by the surgery, then it's referred to as subcutaneous emphysema. Now, on physical assessment, if a patient had this, you would see the skin was edematous. But when you touched it, you would feel something called tactile crepitus, a crackling feeling under your fingers because of the crackling under the skin created by air. Since the air generally comes from the chest, subcutaneous emphysema usually occurs in the chest, neck, face, where it's able to travel from the chest cavity along the muscle fascia out to the skin. But it can occur all over your body as a consequence of air escaping from the lung as a result of trauma. And as I said, some people, and you as well, can refer to it as surgical emphysema, but unless it's been caused by surgery, such as thoracic surgery, partial pneumonectomy, lobectomy, pneumonectomy, some form of procedure where the lung has now been entered through the pleura and air escapes. On the chest X-ray that you're looking at, there's a surgical procedure where you can see clips as a result of the procedure that was done, and air, blackness, radiolucency is in the tissues. Remember, the subcutaneous tissues are off-white or grey, not black. And they're typically homogeneous, whiteness, greyness, not patchy with blackness. This is called the sunburst sign, and the X-ray that you're looking at is showing extensive subcutaneous emphysema. So you've got streaks and lines in all directions. If you saw the patient physically, they would have air in their face, skin, neck, skin, chest, skin, maybe even the abdominal skin. And when you look at the chest X-ray as well, you can see that there is pericardial air, continuous diaphragm sign, and I'm sure that there would be a pneumothorax as well. Now let's review Pneumo-peritoneum. As it says, there's air in the peritoneum, and normally there's no air in the peritoneum. There's only organs. There's only fat. There's only peritoneum. So a pneumo-peritoneum is the presence of air or gas in the abdominal or peritoneal cavity. And the most common cause is a perforation of an abdominal organ or part of the bowel. Other causes could include perforation caused by a benign ulcer, a tumour, or again, other forms of trauma. Now remember where the black radiolucent images should normally appear. As indicated by the X-ray in front of you, you've got air under the right hemidiaphragm. Now normally the liver is there, and the liver still is there, but there's air that is now situated under the right hemidiaphragm. So this would be an erect film because air will gravitate up. Here's another example where you've got bilateral free air under the right and the left hemidiaphragm. You can see the diaphragm is now indicated by a white line, which typically you wouldn't see as a white line, but because there is air under the diaphragm, it's highlighted. Because remember, the diaphragm is tissue. But under normal circumstances, the liver would be sitting there, so the diaphragm and the liver would be combined. On the left hemidiaphragm, you can see a line as well, free air. And typically you'd see a gas bubble under there, which we're not seeing, it's a little bit lower down. But remember, other organs that are related to the heart, you've got the spleen there, you've got the pancreas there, you've got the bowel there, which may or may not be full of air. This is an example of pneumo-peritoneum. But the patient may have already told you that they sustained an abdominal trauma in a motor vehicle accident, someone hit them, or they suddenly had pain in their abdomen. Again, this is a massive amount of free air in the abdominal cavity. And typically here, an abdominal X-ray would be taken as well. Okay, so now let's see what you've picked up. Let's review black images on chest X-ray, radiolucent images. Always again, remember to evaluate the x-rays with the patient's history in conjunction with their physical assessment findings, how they're feeling, how are they clinically. If possible, review the x-ray with serial x-rays that have been previously taken to see whether things have improved or whether things have got worse or whether things are new. And always remember the technical quality of the x-ray, projection, orientation, penetration, rotation and degree of inspiration, because these can affect how the image appears. Right, have a look at this chest x-ray. You've got big lungs, horizontal ribs, widely spaced intercostal spaces, and yes, obviously this is a female because you've got increased whiteness in both middle lobes and lower lobes as a consequence of increased breast tissue. So this is chronic obstructive pulmonary disease, and what you can see are decreased vascular markings as a result of bullous disease, or bullae bilaterally. What do you think about this one? Look at the x-ray, look at symmetry. Right and left lungs are not the same. The right lung is blacker. The right lung appears bigger. There seems to be some tracheal deviation. There also appears to be mediastinal shift, which is causing compression of the left lung. The right lung's missing. This is an example of tension pneumothorax, a life-threatening condition. Okay, what do you think? The arrows are highlighting the mediastinum. The upper area, which contains superior vena cava, jugular vein, aorta, heart, you've got air surrounding the heart. This is an example of Pneumo-mediastinum. Now you've got a lot of air bilaterally under the right hemidiaphragm and under the left hemidiaphragm, which is abnormal. Unless you've got a gas bubble, which again with a gas bubble you can see it is a bubble. There's no bubble here under the left or the right hemidiaphragm. This is an example of Pneumo-peritoneum. Similar, but not similar to a previous one, because it's focusing on the heart. Technically you wouldn't be wrong in saying what it was previously, but we're not going to say that. You've now got air in an area that should be radio opaque, the heart. So therefore this is an example of Pneumo-pericardium. Air within the pericardial sac. And typically it's not life-threatening. The air will eventually be absorbed. Okay, what do you think about this one? You've got streaks throughout. You've got blackness in places where it shouldn't be. You've got blackness in the subcutaneous tissues, in the neck, across the chest. You may even have a Pneumo-peritoneum bilaterally. There's a degree of the continuous diaphragm sign. This is an example of subcutaneous emphysema, possibly related to ventilation. The patient's got an endotracheal tube, which we'll be discussing in workshop or Learn Shop 5. Here's a paediatric patient. Look at symmetry of the lungs. Look at the trachea. Look at the mediastinum. Look at the left lung. Look at the right lung. This is an example of pneumothorax, probably a tension pneumothorax. And this is a combination again of radiolucency and radio-opaque anomalies. Just for interest, for your point of view. So what you've got there is left upper lobe, very black compared to the right upper lobe. Left lower lobe, very white compared to the right lower lobe and middle lobe. If this was a film taken in the erect position, which I assume it would be, we can see that there is a fluid level on the left side of the thorax. So this would be an example of a combined left-sided Pneumo-Hemothorax. But on physical examination, the patient would be in trouble. They would probably be unstable. And last, but by certainly no means least, we look at this chest X-ray. Hyperinflated lungs, elongated shadow, and if we eliminated the fact that again it's probably been maybe underpenetrated, we can still see the vascular markings throughout the lung fields. We can see the ribs, the intercostal spaces. We can see the elongated shadow, the flattened hemidiaphragms. This would probably be an example of a classic chest X-ray for a chronic obstructive pulmonary disease patient. So this is the end of chest interpretation part 3. If you've enjoyed it, I hope I'll see you partaking in part 4, which deals with cardiac anomalies on chest x-ray. And look, if you're interested in these workshops or Learn shops, go to other Dr. Manny Learn shops on YouTube.